indirect. The transmission of the SARS-CoV-2 can occur through infected situation when an infected person coughs, sneezes, talks, or sings. Moreover, the infected individuals can expel the droplets on the surface or objects from hours to days. However, do you know COVID-19 is sexually transmitted disease? Let's move to another part, the mechanism. There are human receptors play an important role in the mechanism of SARS-CoV-2 infection. The capability of SARS-CoV-2 entry via ACE2 receptor with bind protein of the virus and activate surface TMPRSS2 to facilitate the virus receptor fusion. Looking at from the bar chart, you can see that the ACE2 and TMPRSS2 can be found on prostate gland, urethra, testes, and ovary. Let's move to another part about the ways of transmission. The first rule I want to mention is the penis vaginal rule. Figure A tells us about the spermatogenesis process. The figure B describes the ACE2 and TMPRSS2 expression among various stages of reproductive genitalia. This is a systematic review on the investigation of SARS-CoV-2 in semen. Based on the current literature, the authors confirmed the presence of SARS-CoV-2 in semen in 1 out of the 8 reported studies and totaling 4.3% of the population screened. The ACE2 expression is higher in the lung, intestine, and kidney, but it was also high in urothelial cells, which may be a link with lower urinary tract symptoms. This study was conducted on 10 patients to know whether the SARS-CoV-2 in the urethral swab or not. Interestingly, the result tells us all 10 patients had a negative urethral swab for SARS-CoV-2, although the renal oropharyngeal swab was positive for SARS-CoV-2. Let's move on the female genital tract. According to the RNA sequencing data, 7 ovarian cell types show that the degree of ACE2 and TMPRSS2 co-expression in with the oocyte maturity. The ACE2 is more predominantly expressed in the oocyte than TMPRSS2. This study to evaluate the SARS-CoV-2 in the vaginal secretions of women with COVID-19. The study concluded that detection of SARS-CoV-2 in vaginal secretions of patients diagnosed with COVID-19 is rare. Another study from China was carried on 10 women with confirmed severe COVID-19 pneumonia. The study also confirmed that no SARS-CoV-2 virus existing in vaginal fluids of severe COVID-19 patients. Another study from Turkey was conducted on women who was between the ages of 18 to 50 years. The study also tells us SARS-CoV virus were not detected in vaginal fluids of the patients who tested positive for COVID-19. Now we talk about a systematic review. Is sexual transmitted disease caused by the coronavirus? Based on the current worst public information, COVID-19 is not an STD. Let's move to another rule of transmission, oral genital rule. Viral particles may be transmitted through oral sex and use of saliva as lubricant. How about the oral anal or penis anal rule? The ACE2 messenger RNA is highly expressed in the gastrointestinal system, and the immunoproliferation data show that the ACE2 protein is abundantly present in the granular cells of rectal epithelium. ACE2 also can be found on the mucosa of oral cavity. Another study on infants with a COVID-19 who continue to test positive in the anal swabs even after 14 days of testing negative by nasopharyngeal swab test. Therefore, maybe two ways of transmission, directly and indirectly. Directly, that means through oral anal contacts. Indirectly means with exposure with the rectal mucosa to the saliva for lubrication during anal sex. We talk about the last one of my presentation, sexual practice. If a partner is living in the same household, after passing quarantine time, they recommend that having regular sex. If a partner during the quarantine time, sexual activity with condom and with coital penetrative positions, avoid kissing, oral and anal sex. If a partner with any suspicious clinic at any time, avoid coital sexual activity for 28 days. Or a partner with positive COVID-19, avoid coital sexual activity for 28 days. How about the pregnant? Sexual activity with whatever penetrative position is recommended. Avoid kissing, oral, and anal sex. Use condoms. If the partner in contact with the patient who was diagnosed with COVID-19, they recommend that avoid coital sexual activity. How about the partner is not living in the same household? Avoid sporadic couple, use of condom, dental dam, and similar protection methods during intercourse. In conclusion, there was no study to evaluate the risk of sexual intercourse in the COVID-19 pandemic period. The patients remained positive for COVID-19 increase after pharyngeal swab turned negative. Vaginal transudate is free of SARS-CoV-2. It is unknown whether there is a relationship between sexual practice and the risk of spreading SARS-CoV-2. Thank you for your listening.
Good afternoon, ladies and gentlemen. It's such a pleasure for me to give my presentation today. And the topic of my presentation today is about how COVID-19 is changing sun protection habits. And as we know, COVID-19 pandemic has become a worldwide problem, and it has changed attitude and behaviors concerning cosmetic care and procedure among patients presenting to the dermatology outpatient clinics. And as this table shows that, we can see that before the pandemic and during the pandemic, the usings of the cosmetic products is not having the significant differences between the usings of cleanser, anti-aging product, moisturizer, anti-spot product, and also the sunscreen. However, specifically using of the sunscreen before and during the pandemic, we can see that the using of sunscreen on the face, around the eyes, and also the body before the pandemic and during the pandemic, people have the tendency to reduce the using of sunscreen. And the reason for this reducing of using sunscreen is maybe because due to the three main reasons, in my opinion. The first one is that people who thinks that they stay at home and because of the social distancing, they stay at home so that they can avoid from the direct contact to the UV radiations, so that they do not need to use the sunscreen or they do not need to wear the sunscreen anymore because they do not have the direct contact. And the second reason is that because we have to wear mask for a long time, and if we wear mask for a long time, it cover most of the part of the face so that they do not need to use the sunscreen underneath the mask. And last but not least, the chemical sunscreen sensitivity and comedogenicity increase under occlusions. So that because of the occlusions, it can cause mask day if they have to wear mask for a long time. And because of the afraid of having mask day, so that the patient afraid to use the sunscreen because it can make the occlusions is more severe. And with that three reasons that make the people have the tendency to reduce the using of sunscreen. And thus the fact that reducing using sunscreen in the COVID-19 pandemic can cause the skin problems. We will figure out in the next slide. And with the first reasons, if people thinking that they stay at home to fight coronavirus, and because of stay inside, they do not have the contact, do not have the direct contact to the UV radiations, so that they can protect from the sunlight. And how about the realities? The reality is that the lockdown had curbed the processes of melanogenesis, hyperkeratosis, and epidermal hyperplasia in response to the gradual adapt of the skin to sunlight, and so that it's making the skin more sensitive to more aggressive and energetic solar irradiations. And in addition, the photoimmune response may be affected by the fact of by the lack of exposure to sunlight, thus favoring an increase in the incidence of photosensitivity disorder. People who keen to be outdoors after the long lockdown period, there is clearly an increased risk of sunburn, and the skin has had no time to adapt, and this could have long-term repercussions in the form of an increased incidence of skin cancer. And so that with the first reason, if people think that they stay at home, they stay away from the sunlight, but that is not true. If they stay at home, it makes the skin more sensitive to UV radiation. So that if it contact to the UV radiations, they can easily get the sunburn or increase the risk of skin cancer. And how about the second reason? With the second reason, if they think that they wear a mask, they do not need to use the sunscreen underneath the mask. And how about the realities? And the reality is that the surgical masks and respirators, for example, the N95, are tested for bacterial filtration efficiency, particle filtrations, breathing resistance, and splash resistance. To our knowledge, the UPF of this product is largely unknown, likely because medical masks were not designed with the intention of being used outdoors or outside of healthcare settings. An analysis of medical masks in this context is difficult because the UV protection of this material depends on the type and quantity of fiber additives, such as antioxidant or UV stabilizers. And the first medical mask is the surgical mask, and the surgical masks are most commonly made of 3 to 4 layers of non-woven polypropylene, which is a raw fiber is highly susceptible to oxidative degradation for both UV radiations and visible light. In recent study, the polypropylene transmitted 40 to 70% of UV rays and only have a UVF between the 6 to 11. And how about the respirators, such as N95s? The respirators, such as N95, are made of several non-woven synthetic layers and offer better virus filtrations due to electrostatic charge and are closer to the face. And the ultrafine filtration layer is typically composed of meltable polypropylene that is then placed between multiple other polyester layers. So that can make the respirators such as N95 likely better than surgical masks for sun protections due to their polyester content. However, given the shortage of respirators during the pandemic, they are not recommended to the public for UV protections because the UPF of the N95 is really unknown. And so that both surgical masks and also the respirators such as N95 is not recommended for UV protections. And surprisingly, homemade cloth masks earn UVB protection score of between the 400 and 500. Such values are not likely to be reached with topical products with limited, for which the 2006 recommendations limited display value to 50 over for an experimental determined value greater than 60 have the UPF and UVF UVA. And we can see that the most study based on the literature, the best mask choice for sun-aware consumer is a black, dense woven, 3-layer mask composed of polyester or a combination of polyester and natural fibers. And the ultimate method of ensuring excellent UV protection is to select a mask with a UPF 50 label and a seal of a reputable organization. And the fact is that if people thinking that they wear mask is enough and they do not need to use the sunscreen underneath the mask because the mask can cover most part of the face, it is not true because we can have some part the mask only, not cover all of the face. We still have some part of the face not covered by the mask like the forehead and also the ear. And the secondly reasons is that if they cover the mask, it can make the patient incautious with the sun UV radiation because they think that they have the mask so that they do not seek for the shade or they do not need to use the additional physical protection from the sunlight. And it can cause the harmful effect on the skin. And last but not least, if we wear mask for a long time, it can cause masking and it will harmful for the skin. And so that we analyze the second reasons. If we think that the patient wear mask for a long time and it will protect the skin from the sunlight, it is not true because both the surgical mask and the respirators such as N95 have not recommended for UV protections. And not only they do not have the UV protections, but they can make the patient incautious because can make the patient incautious with the UV with the sunlight, and they do not seek for the shade or they do not use additional physical protection from the sunlight. And last but not least, we stay at home and we have to work from home. And by some estimate, we spend 50% of our life staring at the screen. And especially during the COVID-19 pandemic, we had to work from home. And when many of us are spending more time indoors and in front of screens like the laptop and also the smartphone than normal, we are substantially increasing our exposure. And we are exposure more to the blue light like the laptop and the sunscreen and like the laptop and also the smartphone. So it's particularly important to understand the effects of blue light. So what is the blue light and how about the characteristic of blue light? And the spectral characteristic of visible light induced pigmentation and visible light protection factor have been described in 2019 by Indemnit Coley. And also we can see that the light emitted from smartphone screen and can taking selfies can cause premature aging and wrinkle. And also, the visible light can cause some harmful effect in photodermatology. And the source of light beyond the UV, we can see that we visible light, especially the violet blue high energy visible light, have been shown to cause indirect DNA damage by a generation of free radicals and oxidative stress. In fact, 50% of the generated growth in the skin during sun exposure have been associated with the visible light portion of the solar radiation, so that the visible light can cause much harmful for the skin, much more than UVA and UVB. And we have many sources of light beyond the UV. With the outdoors, we have the solar radiation. And with the indoors, we have the energy efficient artificial light sources like the LEDs and the compact fluorescent light have more than 30% of high energy visible light emissions. And with the electronic device, if we think that we use more electronic device is not harmful for your skin, this is not true and you are so wrong, because the electronic device like the smartphone, the laptop and the TV screen, computer monitors can emit more than 30% of the high energy visible light, and it can cause harmful for the skin too. And we can figure out, we analyze this, the high energy visible light effects, and we can figure out that why the high energy visible light have the harmful effect on the skin. And high energy visible light effects can make the reactive oxygen species are generated, and it can lead to the DNA damage and thereby causing inflammations and the breakdown of the healthy collagen and elastin, and it can make the face more crinkles and its uneven texture on the face, as well as the hyperpigmentations. And blue light has been reported contribute to the eye strain as well as cataracts, glaucoma, and other eye disease. And to prevent these conditions, keep at least 12 inches between you and your screen and take frequently break. And we can see that as we now, there are no commonly understood the threshold for when time spent in front of a screen starts to show on your skin. And so that we need to use the sunscreen to protect our skin not only from the UV radiation but also from the visible light. And we have many reviews that talk about that problem. And in this review, we can see that the tinted sunscreen are beneficial for patients with visible light induced photodermatitis and those with hyperpigmentation disorders such as melasma and post-inflammatory hyperpigmentations. And also have a new proposal for evaluations the effect of sunscreen protection against visible light, and it also shows that pigmented product provide more effective photo protection within that band. And so that if we use the tinted screen, can help us against the visible light. And for the conclusions, our review highlighting the UV protection property of mask raised the questions. Mask cannot have adequate sun protection alone, and need sunscreen use under the mask also required. And since the UV filtration level conferred by individual masks is largely unknown, so that it may be wise to wear sunscreen underneath the face mask, and we need to use the broad spectrum sunscreen under the face mask is recommended. And we not only protect our skin from UV radiation, but also the visible light, and so that it is recommended to use the tinted sunscreen. And we need to know that the protect not only for the face but also for the ear and the hand and the body. And if we protect the skin well in front of the sunlight, we can reduce the severity of skin conditions exacerbated by sunlight, for example melasma and skin cancer during the pandemic. And this is the end of my presentation. Thank you so much for your pay attention.
Afternoon, everyone. 4 years ago, anticoagulants are unfamiliar drug class with dermatologists, but the COVID pandemic has changed everything. In field hospitals, anticoagulants as well as systemic corticosteroids are widely used by dermatologists and physicians in other specialties to treat severe COVID patients. So are there any other applications of anticoagulants in dermatology? And are there any other issues that the dermatologist should be aware of when treating patients who are on anticoagulants? My presentations have 4 parts. First one, I will talk about the role of anticoagulants. This is the coagulation cascade that we all knew back when we were a medical student. But just not skip it. All right. There are 4 groups of anticoagulants. The first one is heparins, which include unfractionated heparin, which we also call heparin, and also low molecular weight heparin, enoxaparin. The second one is vitamin K antagonist, which include warfarin and ацетилкумарин. The third one is factor Xa inhibitor, direct factor Xa inhibitors. They have rivaroxaban and apixaban, and the final one is direct thrombin inhibitors. Yeah, they have the biggest range. So the difference between the direct inhibitors and the other 2 groups is in the direct inhibitors, rivaroxaban, apixaban, the biggest range, they directly bind to factor Xa or factor 2 to inhibit them, and they can be taken by mouth, which give them the name DOAC, direct oral anticoagulant. In case of heparin, they have to bind to another protein before they can inhibit factor Xa and factor 2. So anticoagulants are used to treat venous thromboembolisms, such as deep venous thrombosis, pulmonary embolisms, and acute coronary syndrome. They can also be used to prevent thrombosis in patients with atrial fibrillations, after myocardial infarctions, patients with prosthetic heart valve, or in bedridden patients who have undergone orthopedic surgery. So what are the adverse events of anticoagulants? The first one is skin necrosis, which have been reported to be caused by heparin, vitamin K antagonist, and DOAC. The mechanism is the imbalance between anticoagulant and proagulant, and in case of heparin-induced thrombocytopenia. We need to stop the drug and switch to another anticoagulant, and the patients may need skin debridement or skin grafting. The lesion usually start with more petechia and then progress to ecchymosis and hemorrhagic bullae. And ultimately, it can worsen to complete skin necrosis, which can infiltrate deep into the subcutaneous fat, which lead to infection, sepsis, or even death. The second adverse reactions in non-nephrogenic calciphylaxis, which is calciphylaxis in people with normal kidney functions, and it's only been reported to be called warfarin. And luckily, warfarin nowadays have been replaced mostly by other newer and safer anticoagulants. The lesion usually start with erythematous or skin color deep-seated nodules in the lower legs, and then progress to retiform purpura. As you can see here, this is retiform purpura, and then central necrosis with dry eschar. And on histology, we can see that there is calcium inside the blood vessel. And of course, we need to stop the stroke and use intravenous sodium thiosulfate to treat the patients. The third one is urticaria and hypersensitivity reactions. These are rather common drug reactions, not only with anticoagulants, and it has been reported to be caused by heparin, vitamin K, and DOAC. We need to stop the stroke and use systemic corticosteroid for the patients. The final one is cutaneous leukocytoclastic vasculitis, LCV. And again, heparin, vitamin K antagonists in DOAC can cause the reactions. And they usually start with palpable, tachycardia, and purpuric, non-blanchable purpura. And then with the focal ischemia and superficial infarction, superficial skin infarctions can develop, which can progress to vesicular or hemorrhagic poly, and ultimately to ulceration plaque of papules. And this is the histology of vasculitis. We can see that the blood vessel walls is destroyed by many cells. There is fibrinal necrosis inside the blood vessel, and also extravasated black blood cells around. So let's move to another part. Antithrombic medications in cutaneous surgery. All people, nowadays the average skin patients are all people in their 6th to 7th, 8th decade who was on anticoagulants because of their comorbidities. And with the ever increasing number of dermatology surgical patients presenting for dermatology surgery, the dermatology surgeon had to face a challenge